why if someone has angina and the angina is precipitated by activity, the way to decrease O2 demand on myocardium is to make the person stop the activity. So if walking causes the problem, you would make the person stop walking. You got it? And how do you increase the oxygen supply? Well, you either put a supplemental O2 on them, but you could also vasodilate them to a certain degree to increase the blood supply, right? And then by increasing the blood supply, you will get more oxygen to them. But the goal of treatment is to decrease the workload of the heart, and you're going to see that with some meds, and to increase the O2 supply. Because the reason why the person's having chest pain is their O2 supply is diminished because of the increased workload. Does everyone get that? Because that's key. So, how are some ways that we can decrease O2 demand and increase oxygen supply? We can do it with medication. One medication is nitroglycerin. Why is nitroglycerin good? Because it is a vasodilator that specifically will increase coronary artery blood flow. Nitro can be given in a multitude of ways: sublingual, spray, capsule, ointment, IV. It actually just depends on why the person's getting it, how quickly they need the action to start. I have a whole thing about nitro, but the biggest side effect of it is probably flushing and a headache, and I'll show you how you work around that. Another classification of meds that will decrease the workload of the heart are calcium channel blockers. They decrease the workload of the heart by decreasing the heart rate and decreasing the strength of contraction. So if I can bring someone's heart rate down, then the workload of the heart is decreased. Get it? The same as if I can decrease the strength of the contraction a little, that will also decrease the workload of the heart, and hence, hopefully, keep the O2 demand low so that the patient doesn't have chest pain. Another way is by giving beta blockers. Beta blockers also decrease myocardial oxygen consumption by decreasing the heart rate, by decreasing the blood pressure, and decreasing contractility. Beta blockers are those meds that end in LOL. Beta blockers are commonly used after someone has an MI to decrease the incidence of complications after, and to decrease the size of the damage. Another medication you have to know are antiplatelet meds. They're used widely in cardiology. Antiplatelets decrease platelet aggregation, and that leads to contributing to atherosclerosis and clots. So commonly a patient will be on an antiplatelet medicine like aspirin, clopidogrel, and a medication that you're going to come across that you should have come across in the SIM is ticagrelor. That's another antiplatelet medication, okay? Basically, all the antiplatelets work the same by decreasing platelet aggregation. Some are stronger than others. Ticagrelor is definitely stronger than clopidogrel. You always have to watch out for bleeding with these patients. And what I want to say about ticagrelor is your patient cannot be consuming any grapefruit. It's another one of those grapefruit meds, because there's a substance that's released from grapefruit that interferes with a lot of medications, and usually what it does is it potentiates the effect of the med. So people on that particular antiplatelet med cannot have anything with grapefruit, because it potentiates the effect of the med, and then your patients can bleed out. Another classification of meds patients will be on is anticoagulants, because they prevent thrombus formation, and that's meds heparin and enoxaparin. What do you do if you have a patient with angina? So basically on admission, you want to talk to the patient about their symptoms, and you always want to ask the question, What were you doing right before you had the pain? Key question, okay? So what were you doing? And you're going to go through your whole PQRST thing. What precipitated it? What's the quality? Does it radiate anywhere? What's the severity? How long is it lasting? Stuff like that. Have you ever had this pain before? You want to kind of get a history. Maybe this is something new that's happening to the patient, or maybe this is something that's been happening a while. Do you experience any other symptoms with pain? As we discussed, and if you did your VSIM, you would know Mr. Shapiro there had a lot of symptoms associated with his chest pain, but typically people will get diaphoretic, have nausea, they might look pale, they might break out in a sweat, pain might radiate somewhere that's non-conventional, so you have to ask a lot of questions about this. If a hospitalized patient reports pain, because this is always a thing, you guys always want the formula, so if there's a question on an exam, and we're talking about a patient who's in the hospital that has pain, well, you will treat that person obviously differently than if you were giving a patient advice, discharge teaching, if they were to experience pain at home, okay? So, if a hospitalized patient reports pain, the nurse has to take immediate action, and many things are done simultaneously. So, if I know that an increased workload is what precipitated the pain and will probably make pain worse, what are you going to tell your patient to do? Stop whatever they are doing. If they're in the hospital, you're going to sit them down. If they're in the hallway, you're going to get a chair and sit them down. You're not going to make them walk back to their room, or you're going to get the wheelchair to transport them back, but they're not walking on their own. All right? You're going to put them in their bed and put them in semi-Fowlers. You want the head of the bed elevated because you want to increase O2, right? So we're going to elevate the head of the bed. Unless what? Unless what? Why wouldn't I do that? Why wouldn't I elevate the head of the bed all the way in high Fowlers?
The blood pressure being low?
Blood pressure too high. Ayuna, you have to have your camera on, Dina and Angelina and whoever else is over there.
Professor, I'm sorry to sidetrack a question. Are you going to send this recording to us?
No. You have to be here in class. Department policy, camera has to be on.
Okay. Oh no, I understand that. It's recording, so I thought
I am recording it just in case, but I am recording it. But I won't typically share it, okay, if you're present. I know I'm being recorded anyway. So patient's going to stop activity. You're going to put them in the bed, head of the bed elevated, okay? You're going to assess their pain. Tell me what you're feeling. When did it start? Where does it radiate? Things like that. Vital signs. You're going to assess the patient for sorry, I don't know why that happened. God had to teach by Zoom. Gonna assess their vital signs, assess them for respiratory distress, gonna do a 12-lead ECG right away. If the patient's in the hospital, remember we always assess a patient first, okay? And how do we assess them? One initial thing is always vital signs, because what did I tell you? Someone might have an abnormal lab value, like a low potassium or something, or a minor dysrhythmia. But we always want to do vital signs because we want to know how is this affecting our patient, okay? A lot of you jump to doing interventions on the exam and went right beyond the first intervention that should have been assess vital signs. Because invariably, I'm going to tell you what's going to happen. Your patient's going to have chest pain or anything. Your patient's going to have anything. you're gonna call the healthcare provider because you know you have to call the healthcare provider. You need an order, it's something you can't do independently, whatever. Do you know the first question the healthcare provider is gonna ask you?
What are the vital signs?
What is the patient's vital signs? Okay, so you need to do vital signs to see how is this affecting my patient, because that will determine the plan of care. Imagine if this patient was having chest pain and was hypotensive immediately at 80/60. You might rethink that nitroglycerin, right? Your healthcare provider might tell you to do something else. You follow what I'm saying? So you please.
Professor, I have a question. So you spoke about the exam. There was a specific question where it was like
I'm
either
not
call the
talking questions on
HCP.
exams.
No.
Maria.
I'm just using the example. So when you have two options of like calling the health provider, but also the vital signs come first before calling the
Yes,
provider,
that's
correct?
what I'm saying. Because invariably, someone's going to say to you, "What are the vital signs of your patient?" What are you going to say? "Oh, I didn't take them."
Right.
Like that's always should be part of your assessment of a patient. Okay, let me see how whatever is going on with them is affecting them. Because sometimes, in fact, I gave the example in class about people's heart rates. Some people can have a heart rate of 40 and be totally okay. So before you panic, let me see how this heart rate of 40 is affecting my patient. And then when I call the healthcare provider, I can give a clear picture of how this is affecting my patient. So vital signs, assess for respiratory distress, do that 12-week EKG. Nitro may be given depending on those vital signs and what's going on. And then typically what happens is the vital signs in ECG is done between all of the doses. Because let's see, when I started, the patient's BP was 150/80 because he was so anxious because he was having the chest pain. I've now given one dose of nitro. Patient saying to me, "Nurse, I really don't feel well. Something's wrong." I go take the BP and it's plummeted to 80/60. So that's always gonna dictate, my next step, my next intervention. So vital signs in ECG are monitored between doses. Definitely administer the O2, because what is the problem here? Decreased oxygen going to the myocardium. So let's give some supplemental oxygen, and of course, notify the healthcare provider.
Professor, in that case, that medicine, specifically the nitroglycerin, is not good because of the blood pressure, can you give the dobutamine? I don't know how to pronounce that right.
No, that'll be a healthcare provider decision. And dobutamine, what is the action of dobutamine?
Contractility, and it would increase the blood
it
pressure.
Increase contractility of the heart. If I increase contractility of the heart, and am I increasing somebody's myocardial workload?
Yes.
Would I give dobutamine if somebody had chest pain?
No.
Bingo.
Thank you.
You see how you have to take it. Don't jump at the first most obvious thing. Take it to the next scenario. Think about it. That's critical thinking. Let's talk about nitro. Okay, so nitro increases collateral blood flow. So while it dilates the coronary arteries, it also increases your collateral blood flow, which causes some of the problems that people experience with it. Nitro can be given sublingual. It should be your patient's mouth should be moist. Sublingual means under the tongue, of course, and it's given every 5 minutes times 3. Pain relief usually occurs within 3 minutes. Hence, the progression of giving this is every 5 minutes, because we know it takes about 3 minutes to work. Got it? And then it dissipates really rapidly. So that's why you give it up to 3 times. And you're reassessing the pain and the vitals after every dose. It can also be given intravenously in an ICU setting or an ED, because typically a patient will have close invasive monitoring if they give in IV nitro, because it works very quickly when it is given intravenously. The BP of a patient can drop in less than a minute. So typically when a patient is given nitro for pain, There'll be parameters given by the healthcare provider about how to titrate the medicine and what to do about dosing. If you have a patient going home on nitro, there's some things that you have to make sure you teach them. Because most patients self-administer nitro because they go home with it. So, mouth has to be moist if it's sublingual. If they are using a patch, the patch has to be put on a place where the skin is intact, away from folds and joints, and the location of the patch should be rotated. They do not swallow anything until the pill dissolves underneath their tongue. Nitro typically is distributed in little small containers that are dark brown glass because nitro is inactivated by heat, light, moisture, and air. So the more times a person is opening the container, the more times it's exposed to air. That's why it's in those little small bottles and it's a minimal amount of pills, okay? You want your patient who has angina to carry their nitro with them at all times, but tell them to be mindful of where they carry it. You don't want them to leave it in the car in the middle of the summer, okay? Nitro should just routinely be renewed every 6 months so that your patient always has an unopened bottle ready to go when the open bottle expires. When patients take nitro, because it causes a collateral vasodilation as well as vasodilation in the coronaries, think about what's happening, okay? We're collaterally vasodilating so that sometimes people have a drop in BP. Typically what they get is very flushed in the face and an immediate headache. That's what most people complain about. For the headaches, usually when a patient takes nitro, the headaches start to dissipate over time. So you can tell your patient, if you get the headache, to take ibuprofen or acetaminophen and to give that a shot first before they call their healthcare provider to stop the med. Then typically, if the side effects persist, then the healthcare provider can order the nitro to be delivered in an alternative form. Spray, ointment. Some people take it actually PO, shorter acting nitro, can be taken PO several times a day. And always remind your patient that if they have to take nitro because they have angina, that if the nitro stops working does not work after the third dose, they have to call 911. Another classification of medications that are given for people with angina is calcium channel blockers. Calcium channel blockers enhance vasodilation and myocardial perfusion. They increase blood flow to the heart, okay? They also will, to a degree, decrease contractility. Calcium channel blockers are typically also used for people with hypertension. They are not given after an MI, okay? Not given after an MI. Some of them, the most common ones are verapamil and diltiazem, and you have to tell your patient about a few adverse effects that occur because of them, and it's strictly the adverse effects are related to the vasodilation that the drug causes. Hypotension is one, bradycardia is another. Some calcium channel blockers slow down your heart rate. So they might get bradycardic, they might cause headaches, and they might cause pedal edema. So these are things you have to tell your patient to be cognizant of. If it happens, verapamil will slow your heart rate down, diltiazem will not. They both will cause hypotension, headaches, pedal edema. Okay, so you just have to know which one they're on. They are typically not given after an acute MI, but might be given later on. Beta blockers have been shown to decrease size of infarction by decreasing contractility, therefore decreasing workload of the heart. Beta blockers are medications that end in LOL. Probably have seen beta blockers when you did eyes in nursing 18, because timolol is a beta blocker, okay, the eye drops. But typically for MI, it's propranolol, metoprolol. What do you have to think about when you give beta blockers? Before you give a beta blocker, because of its action on heart rate and blood pressure, you have to take your patient's vital signs and only give the beta blocker within the parameters that are typically prescribed by the healthcare provider, which is usually hold it if the BP is below 90/60 and or the heart rate is less than 60 beats per minute. Okay? The side effects of beta blockers are hypotension, bradycardia, bronchospasm in patients who bronchospasm. And one thing you want to tell your patient to do is never abruptly stop a beta blocker. This is why. Summer, I need that camera on. Why can't you stop them abruptly? So let's think about this. I have a patient that's post-MI. They put on a beta blocker. We have the BP controlled nicely at 110/70, and we have their heart rate controlled nicely at 62 beats per minute. What happens if they abruptly stop the beta blocker, Elijah? What's going to happen?
If they abruptly stop it, the heart rate, it could cause the MI.
Yeah, why? Why?
Because the heart rate will go up and the cardiac contractility will be decreased.
Will be increased.
Increased.
And what will happen when the patient's heart rate goes up? What am I increasing?
The blood pressure.
I'm increasing the workload of the heart and the O2 demand.
Yeah.
Okay, we're given beta blockers and other meds because we kind of want to rest the heart. And the way to rest the heart is to decrease the O2 demand. The easiest way to decrease the oxygen demand of the heart is to decrease the workload. That's why we decrease the heart rate. Because the slower a heart is beating, the less the workload of the heart. The less the workload of the heart is the less oxygen I need to make it function. So we give beta blockers to decrease the heart rate, which indirectly decreases the workload, and then therefore decreases my demand for oxygen. You got it? Okay, everybody, you got it? So imagine that someone's on a beta blocker with those vital signs that I mentioned, and they just abruptly stop taking their meds. Their heart rate's gonna shoot up. Forget about their blood pressure, but their heart rate's gonna shoot up. Increase the oxygen demand of the heart because an increased heart rate increases workload. Okay? Okay.
So, Professor, at that point, that medicine will be titrated like we were learning before? For them to like...
Say somebody's on a beta blocker and they're having a lot of negative side effects like the sleeplessness, BP maybe is going too low, whatever the reason. The healthcare provider is going to cut back on the med slowly and probably add something at the same time, just not to have that reflex. Okay? All right? Got it? Okay.
Professor?
Yeah.
Professor?
Yes, I hear you.
I think asthma is a contraindicator for beta blockers because it causes bronchospasm, so you can't give it to asthmatic patients.
Right. So typically, any people with COPD, beta blockers are prescribed with caution by the healthcare provider. That's not to say they absolutely are not given. Okay. So if you had a patient that you knew had COPD and for whatever reason they were on this beta blocker, remember, it's not a total contraindication, all right? You would really be cognizant of listening to their lung sounds, right? And you would really be cognizant to make sure you taught your patient if you develop unusual shortness of breath, wheeze, whatever, you got to call your healthcare provider.
What about asthmatic patients? Patients that have asthma.
There's no cut and dry rule, and I'm not going to weigh in on that. That is up to a healthcare provider. Okay? That's why it's not up there. All right? Antiplatelet medications. Remember, they prevent platelet aggregation. That's aspirin, clopidogrel, ticagrelor. Something about platelet medication is you have to monitor your patient for unusual bleeding. So, your patient's going home on this. So you got to tell them, be mindful when you're brushing your teeth. Make sure it's a soft toothbrush. You have to check your stools. You have to check your urine. Make sure you tell your healthcare provider if you suddenly get frequent nosebleeds or are noticing petechiae on your body. And of course, you'd have to explain, little red dots or something like that. Antiplatelets. You have to make sure you monitor serum liver enzymes. So the patient should always have baseline enzymes and bilirubin levels done prior to starting antiplatelets. The other thing that's really important to monitor your patient for is thrombotic thrombocytopenia, which is a low platelet count. All right. And then if someone has a low platelet count, they're going to be prone to bleeding. All right, so it's monitoring platelet count, neural symptoms, renal dysfunction, fever are all signs of thrombotic thrombocytopenia, okay? Other anticoagulants a patient might be given are heparin and enoxaparin, which I'm not going to get into because you know about that. So you have to take that knowledge and bring it into cardiac now. Just remember, you got to monitor your coag studies, APTT, PT, and always monitor your patient for signs of bleeding, and you got to teach that as well, right? Morphine is a really good drug and used extensively in cardiology because it has multiple therapeutic effects for the patient. First of all, it relieves pain. So typically what will happen is a patient will come in having had taken nitro or even had nitro in the ED. They might go straight to the morphine because it will relieve pain really quickly. It's given IV. But the other thing about it is it decreases anxiety, which is a great thing when someone has chest pain, because I've never seen a person with chest pain that is not anxious and kind of, getting really upset and flipping out. So it's anti-anxiety, it relieves pain, it decreases circulating catecholamines, so brings BP down, brings heart rate down, also decreases the myocardial oxygen demand because it decreases preload, which is the amount of blood that is in your ventricle right before contraction. So it does a lot of good things to decrease the workload of the heart. Okay, so decreases pain, relieves anxiety, decreases preload. It is given IV push, 2 to 5 milligrams every 5 to 15 minutes, but you really got to watch out for two key things. One is hypotension. Okay, BP can drop precipitously with this. And the other is respiratory depression. So you have to monitor your patient. If their respiratory rate drops below 12, you have to make sure there's naloxone on the floor, okay, because you might have to reverse them. Some people, it also causes nausea and vomiting. They'll vomit right away when you give it to them. And when morphine and other opioids are given over time, they can cause constipation. So typically, if this is something someone's going to be on, and all cardiac patients anyway are on stool softeners, they will be given a stool softener. And in some people, it will cause urinary retention. Who keeps trying to ask a question? Someone trying to ask a question? No?
I think I have 4 extra slides. I have 4 extra slides that you don't have.
I understand. You came late. I said that I have the new slides up. The slides that were originally uploaded were from 2023. I changed the order of the slides, and I'll tell you where I added information. Okay, Lena?
Okay.
Got it? All right. Those might just be out of order.
Yes.
Okay, so we got stable angina down pat, predictable, right? Predictable, relieved by natural arrest. Okay, now, that's when someone has a partial occlusion of a coronary artery. And it's just that once they start an activity, it's not that the occlusion got bigger, but maybe there's less blood flow through a coronary artery because of the activity or something. So that's why they get the pain, all right? In unstable angina, this occlusion is growing, all right? And basically what's happening is now the myocardium has a very significant decrease in O2 demand. Sorry. A very significant decrease in O2 demand because the occlusion is getting bigger. And typically, if action is not taken at this point in time, probably the person's going to sustain a myocardial infarction because the occlusion is going to be complete. Okay, myocardial infarction has multiple terms used to describe it. Heart attack, the proper term is myocardial infarction, okay? And basically, MI is an acute onset of myocardial ischemia that results in myocardial death. And it is caused when a particular coronary artery completely occludes. Usually if someone's having unstable angina, that's a warning that total occlusion and the MI is coming, all right? Sorry. Okay, so we have two categories of MI. We have a STEMI and a non-STEMI. The difference is in a STEMI, the ST stands for ST segment elevation MI. This is an MI. There's no question when you're looking at the EKG, the person has elevation of the ST segment. I believe I have an EKG to show you. There's no question what's going on here. I know this patient's having an MI. Sometimes people will present with very typical symptoms of an MI, including having the positive troponin, which really indicates they are having an MI. Which really indicates they are having an MI, but on EKG, there's no changes of the ST segment. That is what we call a non-STEMI, okay? Cameron, I need that camera on. All right, so signs and symptoms of unstable angina. This is where I have almost total occlusion, and if I don't get the person help at this point, then they are going to progress to having a heart attack, an MI. So it's significant decrease in blood flow to a coronary artery. The coronary artery is not completely occluded yet, but it's getting there, okay? So just think about it. I have a coronary artery, right? And I have an almost complete occlusion of it. So blood flow is still getting through. Now I'm doing an activity, I'm walking, so I'm increasing my oxygen demand. When your heart beats fast, remember I told you way back, when your heart is beating fast, it doesn't adequately fill and empty. Do you recall that?
Yeah.
So if I have a decreased amount of blood flow going through an already almost 100% occluded coronary artery, then that decreased blood flow is going to cause that person to have chest pain because I can't even get the minimum amount through. I have less than the minimum amount going through that coronary artery. So that is what results in the chest pain. So that's why increased activity works against the patient, all right? And an increased heart rate works against the patient and causes the pain. So basically what'll happen is diagnosis is going to be made on presenting symptoms. What kind of chest discomfort the patient's having, the PQRST, it's usually chest pain with minimal exertion. Some people have chest pain at rest with unstable angina. But even when they're not doing anything, the blood is just squeezing through, but it's still not enough, so they have chest pain. The pain might radiate to their neck, their arm, their jaw, their shoulder. Most people tell you it feels like a heavy weight is on their chest. Most people have told me that. Other people might tell you it's like a squeezing, constricting kind of feeling. They have marked limitation of activity. They can't do anything without getting the chest pain. And typically what happens is, as a coronary artery is occluding, they can do less and less activity, and the intensity and frequency of the angina is increasing. Typically, the pain will last more than 15 minutes. So there goes our stable angina rule. It is poorly relieved by nitro. So typically they'll say, I usually can take my nitro and it works after the second one. They're on the third one and they're still getting chest pain. It's typically accompanied by dyspnea, tachycardia, anxiety, fear. Remember, I told you, people with diabetes might have an MI and not experience any kind of chest pain, because just like you get peripheral neuropathy, you can get diabetic neuropathy of the nerves that make you feel pain in your myocardium. So a patient might present that has diabetes and have everything else, hypotension, diaphoresis, the anxiety, the whole thing, and they don't know what's going on. And then you hook them up to the EKG monitor and you see what's going on, even though they're not feeling terrible, terrible pain. Also, women, if you have a female patient that presents with, they usually present atypically. They will tell you they have terrible back pain that's relentless, or burning in their chest, or very, very extreme fatigue. You have to think MI with females. So there is a little phrase in the cardiac world that time is muscle. So American Heart Association, American College of Cardiologists, all these organizations have shown by evidence-based practice that the faster you address a problem, unstable angina, the faster, the better it is for the patient, because you decrease the amount of myocardial tissue that dies. Because when someone sustains a myocardial infarction, there's actual damage to the myocardium and it does not regenerate. So typically, our left ventricle is a muscle. If I sustain an MI that affects an area of my left ventricle, then that portion of the left ventricle that contributes to the pumping action of the heart is not going to exist anymore. And that's how people go into heart failure. Because when portions of the myocardium can't pump effectively, it doesn't contribute to cardiac output, then, we get the backup, and that's how heart failure starts. So it has been shown that if people can get to a facility and get in a cath lab within a 90-minute window to either have thrombolytic therapy, a stent put in, whatever, then we can save someone's myocardium from sustaining permanent damage. So basically, unstable angina going to an MI is because there is blood flow to the myocardium that is abruptly stopped. This could also happen from coronary artery spasm, not just a blockage. Some people get coronary artery spasms where their coronary arteries go into spasm for sustained periods of time and therefore block blood flow. Could be from acute blood loss. If I'm hemorrhaging out, do I have a cardiac output? No, right? I don't have a cardiac output if I'm bleeding out. So I have a decreased amount of oxygenated blood going through my coronary arteries, and I can potentially get an MI from that. Same with cocaine use, because your heart rate speeds up so fast. Platelet aggregation, other reasons why you can have a decreased blood flow. Basically, a diagnosis is made on symptoms, EKG, and labs. So, how do we know what's happening? If the patient is having unstable, the pain comes on acutely, it is not relieved by nitro. Okay, the patient might also have tachycardia, tachypnea, skin is cool, pale, moist, and it can evolve in minutes to hours. Typically what happens is an EKG is done from the time that the patient comes into the system, whether it's via the paramedics or they walk into an ER. That's like the 0 hour, and EKG will be done then. And typically an EKG will be done at least every 10 minutes, because we can see the evolution of an MI on an EKG. Also done right away are troponin, LDH, CPKMB, and sometimes myoglobin, as you learned from Cole Shapiro. So it's interesting, these guidelines for a STEMI were from 2023, and just this week, new guidelines came out for 2025. But we're gonna go on the guidelines from 23, okay? So typically, these are the guidelines if someone comes into any ER around the world with an ST segment elevation MI. What you have to keep in mind is, this is a formula, but multiple steps of the formula are probably happening simultaneously. And the other thing about the formula is, some things will be started in the EMS system if the patient's picked up by an ambulance before they even get to the ER, okay? So we have a person who's having chest pain. We think they're having an MI. What are we gonna do when they're initially seen? Is right away we're going to put oxygen on them, because isn't that the problem? Decrease oxygen, so we're going to put oxygen on them. So it's typically 2 to 6 liters a minute to keep the O2 stat above 95 if they don't have COPD. What else are we going to do? Let's vasodilate them a little and increase the blood flow to the myocardium. Let's increase that oxygenated blood that we're giving them with the nasal cannula to the myocardium. We're going to vasodilate them and give them nitroglycerin. Okay. Another thing we're going to give them is morphine. Why? Because I told you it decreases the workload of the heart by decreasing preload, the amount of blood that is forced out of the heart in contraction. But what else does it do? It relaxes the patient and it relieves the pain. So 3 reasons why we give morphine. We're going to constantly be monitoring this person's vital signs as we're doing things to them. This patient will probably have more than 1 IV put in, because you kind of know that you're going to be pushing meds like the morphine, and who knows what's going to happen. You might have to give them multiple meds. They will be given an aspirin right away. Typically, when a patient is given aspirin when they're suspected of having an MI, it's a baby aspirin that has to be chewed, not swallowed. In fact, I walk around with baby aspirin all the time, and I have it in every floor of my house, just in case someone's having an MI in my presence. So baby aspirin has to be chewed. Typically, the EKG done immediately and then every 10 minutes. And then as per the healthcare provider, of course, the person will be put on a cardiac monitor. They will have bloods drawn right away. Troponin is the best indicator of myocardial damage. Troponin will rise, like I said, within 3 to 6 hours. So you get your answer right away if something's going on here, all right? Then what will happen is, once the patient gets into the system, they will be evaluated for further treatment. this is where the 90-minute window comes in. Because evidence-based practice has shown if a patient can get somewhere within 90 minutes, then we can avert them losing myocardial tissue. So it kind of depends where a patient is, actually, because if we call this door-to-door time. So if a patient is within 90 minutes of a hospital with a cardiac catheterization lab, that's where they're going to go. They're going to go to the place that can do a cardiac catheterization, because the problem with this is a clot, right? So when I used to work in the CC in the Stone Age, before cardiac cath was commonly used, and because initially the facility I worked in had no cath lab, but this is kind of the scenario a lot of places 20 plus years ago. You basically just did whatever you can, supportive care for your patient, and some people lived and some people died, because we were just giving medications and everything externally to the patient to get them over the MI, okay? We were giving them meds, the beta blockers, the nitro, stuff like that. But evidence-based practice has shown that if we can go into that coronary artery and remove the clot, however way we do it, then we can actually stop the MI from happening. So how do we remove the clot? We do a cardiac cath, but then we do a percutaneous coronary intervention, meaning we put a stent in. So we go into the coronary artery, they see where the blockage is, they open up the coronary artery with a stent, blood flow resumes, and they've averted cardiac damage, okay? So that's why now what will happen if a patient has chest pain and they're picked up is they will get them to a hospital that has a cardiac cath lab, okay? Because they want to get in, do the cardiac cath, confirm if this patient is indeed having an MI, and then do next steps from there. So a lot of times people will go directly from the ambulance to the cath lab if they're trying to keep in the 90-minute window.
Is that like law in New York, where if an EMS picks them up and they know it's cardiac related, they would take them to a specific hospital, or no?
These are guidelines from the American College of Cardiology. This is what all hospitals are following. It's not a law in New York State. It is medical guidelines that dictate what happens. Okay? It's medical guidelines that dictate what happens. So this is typical of what will happen. So say you have a patient who's having unstable angina, they're picked up by the ambulance, they know they can get to a cath lab hospital within 90 minutes, that's where they will go. When they get to the cath lab, they'll have the catheterization done, and determining on what the healthcare provider finds, they will either have a stent put in, angioplasty, or go directly for open heart surgery. Sometimes though, you might not be in an area where there's a hospital with a cath lab that you can get to within 90 minutes. So what will be done in that case is then the patient will go and get thrombolytic therapy. Because what would thrombolytic therapy do? Thrombolytic therapy will lyse the clot, right? And that would be the other way to stop the MI from progressing. All right? In addition to all this going on, patients are usually started right away on high V heparin, are given some kind of antiplatelet med, will be started on beta blockers, and things will progress from there. Okay? So, these are guidelines. So, okay. These are guidelines set forth by American Association of Cardiologists, all those bodies of knowledge I told you about. This body of knowledge, doctors, nurses, researchers, develop protocols of how to treat certain conditions. And the treatment comes under another body of knowledge, and we call this ACLS, which is acute coronary life support. Okay, just like you have BCLS, basic life support, now we have another level, and it's for acute conditions that are coronary related, just like we have PALS, which is pediatric advanced life support. Okay, this is advanced cardiac life support. So patient has a cardiac condition. According to ACLS, the healthcare providers are going to go to the algorithm for whatever cardiac condition we're talking about and follow the algorithm. And it's super easy, so that anyone can do that. So you have a patient, this is how you read it. A patient comes into the ER and they're suspected of having an MI, right? So the questions are going to be asked. Why do we suspect they have MI? Is your patient having chest pain that radiates to the arm and jaw? Do they have shoulder pain? Do they have nausea? Are they vomiting? Yes, that makes us suspect they're having an MI. Got it? That's how you follow it. If you see my pointer, right? You guys see the pointer?
Yeah.
Okay, go down to the gray.
Yes.
We suspect the person's having an MI. What are we going to do? We're going to give them aspirin, ECG, nitro every 5 minutes, morphine if they need it. We're going to give oxygen if the pulse ox is less than 94, right? Then we're going to go down some more. We're going to complete a fibrinolytic checklist just in case, because we don't know how this is going to go. All right? Notice on this side, it's actually giving you the 90-minute door-to-door algorithm. If they get to the ED to needle time, I call it door-to-door needle time. For fibrolytics, it's less than 30 minutes. Time for PCI has to be less than 90. So if they can get somewhere, they know they can't get to a PCI, a cath lab that has PCI, but they can get to a hospital that does thrombolytic in less than 30, then that's where they're going. But if we have 90 minutes, they go into the cath lab for PCI. All right, and then you just follow it down. So if they suspect a STEMI because of EKG changes, we're going to look at the symptoms. Did they have symptoms in less than 12 hours? Yes. Then they're probably going to go for some kind of reperfusion protocol, which is the PCI or the thrombolytics. We're going to reperfuse the coronary arteries. If they don't have that, then they're probably going to get admitted to a telemetry bed like Mr. Shapiro, for those of you who did the VSIN. Mr. Shapiro had a non-STEMI and landed up on a telemetry unit. Okay, and that's what happened here. Okay, and then it will determine the adjunctive therapies to do. So you see how it goes? An algorithm is a formula. Step by step, the healthcare providers are guided what to do based on what the patient's symptoms are. And we have algorithms in ACLS for everything. Cardiac rhythm, STEMI, non-STEMI, stuff like that. All right? It's not something that you have to memorize step by step, but you should have an idea of what happens. Okay? Got it? I see a lot of, some of you...
Professor, you mentioned that they have new guidelines. Was this change at all? Was there any huge change to whatever you known already?
Yes, there's some changes, minor, nothing for you to be concerned about, nothing earth-shattering.
Nothing crazy? Okay.
Okay, so you're going to use the 23 guidelines. Okay? So, interventions that you have to be aware of. You're going to assess your patient for symptoms, right? Going to ask the questions, PQRST, what kind of chest pain is it? Does it radiate? What is accompanying the chest pain? Those are interventions. What else do you have to do? Everything is going to be like rapid fire, just going to keep happening. And every time you perform an intervention, you have to reassess your patient. Don't forget to do that. You have to also be asking questions because they're going to give this patient aspirin, right? You have to ask, are you allergic to aspirin? You're thinking this patient might be going for a cardiac cath. That's why they're in your ER, right? You have to ask your patient, are they allergic to shellfish, right? Or if they're allergic to any other medication. They're probably going to be given nitro. They will get morphine. The serial EKGs will be done, and O2 will be given. This is kind of repetitive of what I said before. This is basically the algorithm here. So if someone has an ST elevation MI, we're going to think they might be going for fibrinolytic therapy, or they might be going for a percutaneous intervention, right? But either way, when you have a STEMI, you're going for some kind of reperfusion therapy, something that's going to get the blood flow back into the heart and through the coronary arteries. So fibrinolytic checklist. So we talked about giving patients fibrinolytics, right? When we talked about pulmonary embolism. What do you think are the questions you need to be asking here? What's part of the fibrinolytic checklist? Streptokinase, alteplase. Remember those medications for pulmonary embolism? Same kind of medications are used for fibrinolytic thrombolytic therapy for coronary artery clots. What did you ask your patients then? Can I give anybody a fibrinolytic medication, Shayna? Can I give anyone a fibrinolytic therapy?
I'm thinking.
Okay. Angelina, can I give anyone fibrinolytic therapy?
No.
No. Who can't get it?
People with blood clots or bleeding.
Bleeding disorders.
Yeah.
Carl, who can't get it?
Pregnant woman.
Pregnant. Good. Adina.
Trying to think if they're on like heparin or warfarin, maybe.
Different clotting factor.
Okay.
Cameron.
I was just thinking people with clotting issues or someone that like
You
doesn't
said that.
have good coagulation, so I'm not too sure.
Adina said that. Anastasia. Audio. Think, guys.
People with recent surgeries.
Bingo. Recent surgery. Here we go.
Someone with hypertension.
Not necessarily hypertension. But you're on the track there, Cameron. What does hypertension cause? Natalia?
Hypertension cause
Heart constriction.
increased workload of the heart.
It does, but yes, Bethany, and thank you in the chat. If it is uncontrolled, hypertension can cause stroke. So let's review who cannot get fibrinolytic / thrombolytic therapy. It's all the same thing. It's giving a person intravenously one of those enzymes, alteplase, streptokinase. Okay, is that part familiar at least? Okay, remember, when you get fibrinolytic therapy, the medication destroys all clots in your body. It doesn't have an affinity just for your coronary arteries. It's going after every clot in your body, and it's going to lyse it. So if I had a patient who had a stroke, they have a clot up there in the cerebral artery, right? If I give them fibrinolytic therapy, that medication is gonna lyse the clot that's in their brain, and they're gonna bleed out. Same like if someone had recent surgery. Okay, if someone recently gave birth, if someone is pregnant. Is this coming back to anybody? Remember all this? If someone has a clotting disorder, you cannot get fibrinolytic therapy. I'm giving a patient fibrinolytic therapy. What are nursing interventions that I should be doing to be ahead of if they get a complication from it? Elizabeth, two things. How am I going to
I'm checking their APT and PT teams.
Yeah.
That might help, but they don't work directly on that. How am I going to know if someone is...
Check their mental status because they're bleeding out, so they're...
Yes, Shana. Remember I said you always got to check LOC of patients on fibrinolytic thrombolytic therapy, because if they're bleeding in their head, you are not going to know, right? Because can we see anything that's going on in our heads? No, we can't. But if I have a patient who's lucid 1 minute and totally confused or losing consciousness the next, I got to think that maybe they had a stroke that they were not aware of, and now they're bleeding in their brain, and this is how they're exhibiting a symptom. Okay, just like what is that measurement I always should be doing to catch someone bleeding in the abdomen?
Abdominal girth.
Abdominal girth. So someone's on fibrinolytic therapy, I'm checking abdominal girth. How else am I going to know they're bleeding internally? So if you are really not sure what I just spoke about, because we covered this when we did pulmonary embolism, you guys have to go back and go check it all out, okay? Because you can get thrombolytic fibrinolytic therapy for a multitude of things, but the nursing interventions and evaluations are all the same, okay? All right, so please review it, really important. So let's go back to, so if a patient has a STEMI, I'm actually seeing evidence on the EKG of them having an MI. That I see ST elevation on the MI, all right? So what's gonna happen? We gotta see if they're a candidate for fibrinolytic just in case, so we have to do that checklist. At the same time, they might just initiate PCI protocol instead, and that would be, we have to load the patient up with aspirin, antiplatelet inhibitors, start anticoagulation on them. Typically, of course, they'll have an IV in, they might have IV nitrates going, they will be put on beta blockers if there's no other contraindications, and probably some kind of statins. That's if a patient has a STEMI, okay? If a patient has a non-STEMI, it's gonna be like Mr. Shapiro. He got some antiplatelet medication, which can be an antiplatelet aggregator. Patient will get some aspirin, anticoagulation, and go to a monitored bed. A monitored bed is telemetry, right? You all know what telemetry is? Does anyone not know what telemetry is?
I don't know what it
I'm not
is.
sure what it is.
Isn't it the smart EKG?
Okay.
Because I see one
Okay, so this is telemetry is
in the ICU. It's
okay. So typically, sometimes a patient like Mr. Shapiro was not a candidate to be in an ICU, to have monitoring in an ICU, and it could be any patient that's admitted anywhere in the hospital that for some reason they want to monitor their cardiac status. But maybe it's a post-op patient who had to be on a GI floor, but we still want to know about his cardiac status. So we're going to hook him up to a remote cardiac monitoring. Remote cardiac monitoring is what telemetry is. Basically, a person will have EKG electrodes on them connected to wires in a box, and the signal is transmitted over the Wi-Fi to cardiac monitors that are located somewhere else in the healthcare facility in the hospital. Sometimes the monitors will be right at the nurse's station, okay? Sometimes, and if you're in South Brooklyn Health, on the 4th floor, I forget if it's the east side or the west side, there is a room, there is an office that's called the telemetry monitoring office. Okay, you should talk to your clinical instructor to go in there. In that room, there is probably 30 cardiac monitors that are reading out ECGs of patients that are all over the hospital. And there are cardiologists who are sitting in that room, staring at the monitors all day, interpreting what they're seeing. You got it? And what will happen is, if one of those cardiologists sees something on the monitor on a patient somewhere in the hospital, they will contact the unit to go in and assess the patient. Okay? There used to be a physician in there who loved nursing students, and he would come in and explain the monitors and whatever. So if you're in South Brooklyn Health on the 4th floor, even if you're not on the 4th floor, ask your clinical instructor to bring you to the telemetry unit. Okay? So you might see you come into a patient's room, and I bet it's happened to you. You've come into a patient's room and they had EKG electrodes on their chest. And you're probably thinking, where is the monitor? Okay, the monitor is on another floor in another room, and someone is reading it constantly. Okay, that is telemetry, remote cardiac monitoring. Got it? All right, so like Mr. Shapiro, he wasn't having acute symptoms. They felt he was a little stable, so they put him on a monitored unit, which is telemetry. But someone who's having a STEMI is definitely going to be in a monitored unit like a coronary care unit. That's the difference. Okay, you with me? Good? Can't tell. Some of you look too comfortable to be engaged. Okay, so 3 classifications of MIs. When you hear about someone having a heart attack or an MI, they will describe it in different ways. They will either describe it by the area of infarction of the left ventricle or the right ventricle, okay? They will describe it as whether or not they have ST elevation, and they will describe it by the age. Is this an acute MI? Is this an evolving MI? Or is this an old MI? Within our myocardium, we have a left ventricle and a right ventricle. Our coronary arteries supply very specific areas of our ventricles. So pretty much by looking at an EKG, you can determine which coronary artery actually has the obstruction by knowing what area of the myocardium is reflected on the EKG. Okay? I'm trying to make it real simple. I don't want you to get crazy with this. Okay? So, I can look at an EKG, and you might actually see these terms when you're looking at your patient's chart. The patient had an anterior MI. The patient had a lateral MI. The patient had an inferior MI. Those are areas of the left ventricle, and you can see that on an EKG. And when I see that on an EKG, for example, if I know my patient had an inferior wall MI of the left ventricle, I can pretty much tell you what coronary artery has the blockage. How can I tell you that? Because I know that the right coronary artery supplies the inferior wall of the left ventricle. Got it? So you pretty much know what you're looking at when you see an EKG. And the waveforms will change over time. This EKG, just so you know, is a perfect example of a STEMI. So you see this portion here that's elevated. Typically, normally, this portion of the EKG strip should be flat to baseline. But because it's not and it is elevated, this person has an ST segment elevation MI, okay? Don't go too crazy with waveforms. That's another course. but I just kind of want you to have an understanding of what people are talking about, because you're going to hear the terms STEMI, non-STEMI, all right?
Professor, is this what we see in hyperkalemia? This is the elevated T waves? Or
No.
something else?
No. This is actually the ST segment, and it's coming off. If it was just the T wave, did you have the T wave on, because I didn't teach that first class. Don't you have an EKG for hyperkalemia? It's at this junction that it
Yes.
away.
Yes, we had one. You talk about it.
A T wave would be a very big elevation over here. This here is called the ST segment, and it's coming off the baseline going up. So that's what ST elevation is. And point of time. I can look at this EKG and tell you that this is an evolving STEMI, right? This person's was having a heart attack in real time looking at this EKG. There's other waveforms that I might see on this EKG that would indicate to me that the person had the MI a long time ago, okay? So that's why EKGs are done, because they give you so much information, all right? Just so you know. So right side of the heart, right ventricle, left ventricle. So these are just the coronary arteries, right? Oops. The coronary arteries supply a very particular portion of the heart. All right, you ever hear the term when people say left main, or they had a widowmaker's MI or something like that, and that it's really bad? Have you heard that term? Okay. When you hear that term, it means the person had an occlusion in their LAD, their left anterior descending artery. If you take a look, the LAD goes from up here from the left main all the way down. It basically perfuses the entire left ventricle. So could you imagine when someone has an occlusion in the left anterior descending off of the left main, that they can potentially lose a very large portion of the functionality of their left ventricle? That's why it's called a widowmaker, okay? Because if you have an occlusion here, you lose the functionality of a large part of your left ventricle. This person's going into failure all the time and might even just die of congestive heart failure. You follow? Okay? That's so you have to kind of look. Like before I said that person had an inferior wall MI, oh gosh. I know that what supplies the inferior wall is the right coronary artery. Supplies the right ventricle and part of the inferior wall. So if I have a patient with inferior wall MI, I can say exactly what coronary artery is affected. All right? Don't go crazy here, but just know that there's different coronary arteries that supply different portions of the heart. Okay?
Professor, is there a particular reason why the muscle does not regenerate in the heart?
Just doesn't. Not all tissue regenerates after they die, right? All over our body. Certain things you lose, they don't come back. And the heart is one of them. So this is just to give you a good idea of what happens. So someone has an MI, it affects the right coronary artery that supplies this portion of the heart, which is the right ventricle down to the inferior portion of the left ventricle, and it dies. Now, when this heart goes to pump, it has lost the functionality of everything in purple. So you see how cardiac output can go down? And you see how people go into failure when they have massive MIs? Because the heart as a muscle can't contribute to the pumping action. Got it? This is just a crazy EKG to show you that the waveforms can go in all different directions. And this EKG is literally giving us 12 different views of the heart. I can see 12 different areas of the heart by looking at this EKG. And what physicians do, nurses who read this get a wealth of information from here. what area of the heart, where is the occlusion? Is this an old MI? Is this a new MI? Okay, things like that.
Is the empty parts of this AKGs when the muscle is lost? Because you had mentioned that in a previous class, when that you're able to see on the ECG monitoring that if they had a previous one.
This is an acute MI happening here, and if remember, ST elevation is happening right here. I don't expect you guys to know any of this. I just put it in for point of information so that you have some knowledge when you see STEMI and non-STEMI on your patient's chart, but this is beyond, okay? Beyond. It's another course. But it's just to show you, you know, I'm sure you're all probably thinking, what is a 12-lead EKG? What does that even mean? All right? It's basically just showing you almost simultaneously, literally every 3 seconds, 12 different views of the heart. And it's used as a diagnostic tool because it can date an MI for us. It can tell us the size of an MI. It can tell us the area of an MI. Okay? That's all I need you to know from this. This is not a piece of liver from the butcher, but this is a slice of someone's myocardium. And, oh gosh, get used to this. This is actually an area of infarction, and you can see how it's kind of doesn't look as good as the rest of it, right? So there you go. This is all dead myocardial tissue, and that's a posterior wall MI. That's in the back of someone's left ventricle. Okay, we good? Okay, it's 9:30. I mean, you're home in your own space, so I'm guessing you don't really need a break. If you want to go take a break, you'll take one, right? As I see some of you have done. You're like, I lost a few of you. Okay, now, if you're lucky and you're having chest pain, and they deem you might be having a STEMI, you'd be really lucky if you're near a hospital with a cardiac catheterization lab. Catheterization and angiogram are used interchangeably, but we're going to call them cardiac catheterizations, okay? Basically, a cardiac cath is an invasive procedure used to diagnose structural heart disease and of the heart itself, of the valves, and of the coronary arteries. It is done under moderate sedation. So you would go into the cardiac cath lab awake, given a sedative, just like you're given when you get an endoscopy or a colonoscopy or whatever, and you'd be on the table. Generally, you're in something that looks like a radiology suite. Nurses work in there, PAs work in there. The person doing the cardiac cath is usually a cardiologist or an interventional radiologist. Interventional radiologists do invasive procedures, and they usually specialize in what they do, okay? But typically, cardiologists, patient is sedated. You need to know if they're allergic to shellfish. You need to know their BUN creatinine. You need to make sure there's an informed consent on the chart. Typically, there'll be some patient education ahead of time, telling the person that this is what's going to happen, this is what to expect after. And that's it. Prior to this, prior to the cath happening, your patient will be anticoagulated, okay? Your patient will be given heparin. They will be given a platelet aggregator, all right? They will be given aspirin. Typically, what will happen is, there was a time when the only approach for cardiac cath was in the femoral artery. 90% of the time now, cardiac cath is done through the radial artery. And you can even, on your own, figure out, well, why is that a better approach? Number one, it's a lot shorter trip to go from someone's radial artery into their heart. It's also a lot cleaner, isn't it? The other thing about it is the recovery is a lot quicker because all I have to do is immobilize someone's arm for a few hours after the radial approach, rather than if they have to be have a femoral approach, they're in bed for a period of time with their legs straight. So a lot more complications the femoral way, and that's why more often than not the radial approach is used now. So basically what happens is the catheter will go in through an artery, whether it's the radial or the femoral, and go snaked right up to the person's heart, into the aorta, and right into the ventricle. The patient is then injected with a radioactive isotope dye, and above the patient there will be an X-ray screen, and you will actually be able to visualize the coronary arteries and see what the flow of the contrast material is. This is a picture of a cath, and here's a nice good coronary artery here, and you can see right here where the occlusion is. Okay. Okay. Typically what will happen is you'll be the nurse helping to prep the patient for the cardiac cath. So you will be administering all those meds, right? Making sure informed consent on the chart, the allergies, the whole thing. Patient will go to the cath lab, get whatever they're getting done there, whether it's a stent, angioplasty, or whatever. And then you will typically have the patient post-procedure. A lot of times they come back to a regular cardiac floor. So you will be monitoring the vital signs as per the facility, and you have to constantly be checking that dressing for bleeding. Think about it. They're going into an artery, and the person's anticoagulated. So we're going through a high pressure system, and and the patient's being anticoagulated. There's a big chance for bleeding, isn't there? Okay, but we have some devices to kind of give pressure compression at the site. So basically you will have an order about how long to maintain compression at the site, and typically it is done now by an external device that actually will go either around the patient's wrist or around their femoral region, and it's a device that actually exerts exact pressure on the entry point for the cardiac cath. Okay, and you'll have an order about how much pressure to use and how long the device has to stay in place. So that is your responsibility. Typically, if a patient had a cardiac cath during using the femoral approach, they will be on bed rest for 2 to 6 hours and have to keep the legs straight. If it's the radial approach, obviously it doesn't affect the legs in any way. They might be on bed rest also for 2 to 6 hours and have to keep the arms straight. This is a vascular procedure, correct? So we have to institute, in addition to the ABCs, the letter P. I want to make sure that the patient still has perfusion to their leg or their hand where the catheter was put in. So I am checking the pulse, the pallor. I'm checking for paresthesia, for paralysis, for pain, for poikilothermia in the distal portion of the entry site. I'm monitoring INO because what did I tell you that I'm giving the person that I had to be cognizant of that this stuff can do? Why am I monitoring INO? Lena.
Isn't it because I had a higher chance of bleeding?
Do we monitor INO to check the status of a particular body system?
The renal?
The renal system?
Renal?
Right, because what did I tell you the patient's getting injected into them that can affect their renal status?
Radioactive isotope?
Contrast, yes, radioactive contrast material. that is going to go through the kidneys to get excreted through the body. So it's not uncommon that a person didn't have a problem with their renal status prior to the test, but if they are not encouraged to hydrate after the test, then they can sustain kidney damage. Okay, so it's really important. After cardiac cath, people usually have IVs going to hydrate them, but you would also encourage them to drink a little if they could, to drink a lot if they could, to flush it out of their system. So you always got to be monitoring the INO and the BUN creatinine after the procedure. Okay.
Is this renal dysfunction permanently, or is only while the procedure is going on?
There should be no renal dysfunction.
No, I mean the side effects to the renal side of the body. Is it permanent, or is only while the procedure is going on if they have a side effect from this?
No. Your renal status should not be changed because you had a cardiac cath done if everyone's doing their job. So if I know your BUN creatinine prior and it's normal, and I hydrate you properly with IVs and PO fluids after, when I monitor your BUN and creatinine, it should be okay.
Okay.
The problem occurs when people are not hydrated enough, or someone didn't pick up that they had an elevated creatinine, the patient gets the dye, you can put someone in AKI because of this.
Oh, wow.
So we're trying to prevent a complication from occurring. We should not have a change in renal status. Okay? That the complication's the abnormality. Okay? You follow, Maria?
Yeah.
I don't expect a change in someone's BUN and creatinine just because they had a cardiac cath. That's why they get IV fluids to hydrate them, and that's why you should encourage PO fluids after someone has any procedure, as long as they can tolerate it. That includes getting a dye injected into them. Okay? Typically, after a cardiac cath, a patient will continue to be on some kind of antiplatelet medication, and then you have to monitor post-cath labs. They will also be kept on cardiac monitoring because typically what happens is people will have something that we call reperfusion dysrhythmias. They don't really know why this happens, but typically if someone has a cardiac cath and then has either a stent put in or an angioplasty where they have now opened up the coronary artery and the patient has that return of blood flow through the coronary artery, they actually think that the myocardium gets really excited from that increased blood flow and then goes into some crazy arrhythmia for a very short period of time. And that's called reperfusion arrhythmia. It typically happens post-PCI, and they are not sure why it happens, but they think it occurs from the sudden increase of blood flow returning through a coronary artery. So that's why these patients are on cardiac monitors after the procedure, in case they do have the reperfusion arrhythmia, so we can catch it. Okay?
Professor, would reperfusion dysrhythmias cause cardiac issues?
It's a temporary condition that usually dissipates on its own. It's not sustained. It's VTAC actually. So when it occurs, if it doesn't break right away, it's going to be treated, so it shouldn't cause a cardiac issue. These patients are better off after they've had PCI or something than when they went in the door. Okay, they're better. So this is an example of a female-stop device. Remember I told you there's devices that would be put on the patients to control the bleeding at the insertion site. So you can see how it goes around a patient's below their belly button, right where the femoral artery is at the bend of the leg. And what would happen is you would, like a blood pressure cuff, you would increase the pressure on this using the manometer and the ball to exceed the person's own blood pressure, right? Because I have to exceed the blood pressure in order to exert the effect of stopping the bleed. Got it?
Do these patients will qualify for the umbrella that you had talked about before?
No. No, the umbrella is for DVTs.
Professor, is the pressure on the device increased if the patient's blood pressure increases, or is the steady order?
Okay, that's taking the place of you standing. Okay, back in the day, before they had hemostats and everything, the lowest person on the totem pole had to stand next to the patient with their hand applying pressure on a patient's groin for 30 minutes. Okay, then because we're putting a catheter into someone's artery, it's a high pressure system. We got to make sure that the blood is clotted. Remember, they've been anticoagulated, that they've stopped bleeding before we remove the pressure. Otherwise, someone's going to bleed out. Follow? So now we have these hemostats that do it automatically. You follow?
Yes.
I feel like I got off track.
That's amazing.
Okay.
So it changes pressure automatically?
Typically you're pumping it in manually. You have to adjust it manually, but think about it. If your blood pressure is 120 over 80, I have to put the pressure on the hemostat higher than 120 over 80, correct?
Yes.
If it's below, the pressure from your arterial system is going to spurt out the injection site. So I have to exceed the pressure in your body and pump it up to higher than 120 over 80. Got it? And you're usually given order. All right?
So for this, we will monitor blood pressure in case it increases, so we can increase the pressure.
Yes. Yes.
Okay.
Okay. But you're doing that anyway. All right? Okay. So now, what is PCI? PCI stands for percutaneous across the skin, coronary, into the coronary arteries, interventions. And there's different kinds of PCIs. So you need to know, which one did my patient get? Did my patient get angioplasty? Did my patient get a stent? Most times people are getting stents now. So percutaneous transluminal coronary angioplasty is basically both procedures start with a cardiac cath. We got to get into the coronary arteries. Once we get into the coronary arteries, it's up to the cardiologist to decide, am I putting a stent in this patient, or am I doing angioplasty on this patient? Or is the patient not a candidate for either of those things, and then they're going straight to OR to get a coronary artery bypass graft done? So, starts with the cardiac cath, right? All those things about a cardiac cath are in place. And now the patient will have the catheter introduced into their femoral or radial approach, go up into the aorta and down into the heart, okay? And now we're going to look to see what is the problem, where the occlusion is. What goes into the person first is something that is a hollow catheter, okay? And then in the hollow catheter, the cardiologist can insert several things, all right? And one will be balloon tip. And if they need a stent, they're able to pass the stent into the hollow catheter. Like, the hollow catheter is like a conduit for other things to be inserted into the person. So, if a patient has an occlusion and they just had an angioplasty done, what they'll do is, in the sheath, they'll insert a balloon-tipped catheter. When they get to the point of the occlusion, they inflate the balloon-tipped catheter to try to move the occlusion to the sides of the coronary artery. And that's an angioplasty, where they're using the balloon to open up the coronary artery. Got it? That's angioplasty. The word plasty actually means to reshape. So we're just reshaping the interior of the coronary artery by putting a balloon in there. You got it? That's angioplasty. More often than not, they're going to get a stent done. So stents are done to give structural support to the coronary artery as well as to keep it open. And I have pictures. They found that when people had stents done years ago, that people would re-occlude the stents. And a genius figured out, if we can put a medication on the stent that prevents clots from forming, then people can have stents in for a much longer period of time. So now everyone that gets a stent done pretty much gets a drug-eluting stent, where the stent is actually saturated with a medication that prevents clots from forming on it, and then the stents are lasting infinitely longer. Typically, if someone has a drug-eluting stent in, they will be going home and have to stay on antiplatelet therapy. Usually dual therapy, meaning they will be on aspirin and an antiplatelet medication at the same time for the rest of their life. Okay, so what's the difference? So here is someone's coronary artery, right? So you see where the occlusion is forming. So what happens is, this is the catheter from the catheterization. And if they're just having angioplasty done, once the catheter gets in, remember it's a balloon tip catheter, they will inflate the balloon. Once they get the occlusion pushed to the side, they pull the entire thing comes out. That's an angioplasty. If someone has a stent done, same procedure, but they will leave behind this mesh piece that basically is holding the size of the coronary artery away from the inside of it permanently. You see the difference? The balloon angioplasty, the balloon just moves the inside of the artery, but then the whole thing comes out. The stent is almost the better thing to have, because once it opens the artery up, the balloon, the stent stays behind to keep the opening there. Got it? We got this, everybody?
Professor,
Yeah, Melina.
when they do an angioplasty, and they put the balloon and they come out, does it ever does the occlusion reoccur? Because
Yes, lots of times.
anything.
Yes, lots of times occlusions were reoccurring. More often than not, they're having stents done. It's a better thing to have.
Yeah.
But depending on people's anatomy and the situation, that's up to the cardiologist to decide, okay? But just to know, so you know when someone says, oh, I had an angioplasty or I had a stent, you should know the difference, okay?
Is there a maximum amount of times that you could do that to a patient? It's a muscle and it's stretching and the arteries and everything. Is there a maximum?
What,
The stent, the stent and the balloon, is there a maximum amount of times that they could get that done?
That is all up to the cardiologist.
Oh.
All up to the cardiologist. Yes, some people have so many stents that there's no anatomy there. Say if they come in with a STEMI again, that they can't put another stent in, that's the person that's going for open heart surgery. But that's not a decision you are making. That is a decision that a healthcare provider is going to make, and you just need to know, what do I need to know to prevent complications in my patient who has XYZ? That's all you got to know. But that can happen. Okay, what can happen from a PCI? Think about it. We're going into someone's arterial system with a catheter. We're anticoagulating them. Think of all the things that can happen. One is coronary artery dissection. The coronary artery can be so fragile, the catheter goes right through it, and then they dissect someone's coronary artery. Sometimes coronary arteries don't like to be manipulated, and when they get manipulated, they go into spasm and might close permanently. Person might get a hematoma or bleed at the site. Remember, your person's being anticoagulated, so we got to make sure the hemostat is on, the pressure is applied, we're checking the dressing, we're making sure that they are not bleeding from the site. I see a call. And another thing that can happen is we can give someone an MI from this. Okay, so these are complications that some of them require medication, some require them going right back to the OR. But if you are doing your vital signs and evaluating your patient after the procedure, then the hope is that they won't experience one of these complications. Call, question.
Yes, I wanted to know if it's not the one that they call variant angina when the coronary artery is
Breaking up.
closed by himself.
Wait, you're breaking up. What did you ask me?
I was asking if it's not the one that they call variant angina, because the coronary out.
And variant angina is not consistent. Okay, the patient doesn't have consistent symptoms. And variant angina, the patient constantly experiences different symptoms. That's what variant angina is. Okay, all right. Okay, so nursing interventions post PCI, it is up to you to assess the 6P's distal to catheter insertion. So anytime you have a vascular procedure, you have to always start the 6P's after your ABCs. So you're assessing the insertion site for bleeding, swelling, evidence of a hematoma. You got to monitor the pressure device. You got to monitor the cardiac monitor for dysrhythmias because of the VTAC that we spoke about. You have to assess your patient's renal status so that they don't get AKI, especially when it's a femoral approach and the person might have to be on bed rest for 2 to 6 hours with their legs straight. You want to make sure you're encouraging deep breathing, but you do not want them to be coughing because you don't want to exert pressure at the insertion site in their groin. You're going to monitor the anticoagulation therapy they're on, so that would involve monitoring their coag studies. Remember, if it is a femoral approach, the bed rest can be up to 6 hours. The leg has to be straight. If it's a radial approach, people usually get out of bed once the sedation wears off, which is about an hour or so, and ambulation is encouraged. Typically, if a patient has no complication after PCI, they will go home within a day, but it's determined by the cardiologist, not the nurse. And discharge education, when your patient does go home, is you want to tell them they need to monitor the insertion site for bleeding, that they need to report pain, that if they develop a temperature, they need to contact their healthcare provider, and whether it's femoral or radial, they need to avoid heavy lifting, and if it's femoral, they need to avoid bending for a period of time determined by their healthcare provider. Okay? Good? So that's if someone is near a cath lab and can get there within 90 minutes. If they can't get there within 90 minutes and they can get to a thrombolytic facility within 30, then they will have thrombolytic therapy. Basically, it restores blood flow by dissolving the clot. So this is indicated for ST segment elevation MI. If PCI facility is not available, remember that it will dissolve the clot in the coronary artery, but anywhere else there's a clot in your body. So the contraindications are the one that we spoke of before. Someone mentioned hypertension before, but it really is only if the hypertension is really uncontrolled and severe, okay? This should kind of be a review for you. We already discussed this. If someone is thrombolytic therapy, Level of consciousness is what you have to monitor constantly because you will not know if someone is bleeding in their brain. You have to monitor for other signs that might indicate to you they could be bleeding. Sudden tachycardia that they didn't have prior, which would tell you maybe the patient's bleeding somewhere and getting shocky on you. Hypotension, tachycardia, restlessness. Remember I said restlessness is a sign of cerebral hypoxia as well as bleeding. Got to monitor the H&H, coag studies, and all those places that blood can show up that might not be obvious. Occult blood, emesis, the urine, skin for ecchymosis. That should all be a review. How do we know when someone has reperfused their coronary arteries? They will suddenly say, oh my gosh, I have no more chest pain. Okay, the chest pain goes away because why? They've removed the occlusion that was causing the chest pain. Another way we will know someone has reperfusion is they might get the VTAC after. They might get the reperfusion dyspnea. And the last one is their EKG will actually change. Where they had that high ST elevation, it will actually resolve and go back to baseline. Anticoagulation therapy, this should be a review for you, okay? So they will be put on heparin after any kind of PCI. They will be on it for 3 to 5 days just to prevent immediate reocclusion of the coronary artery, and then you're monitoring the APTT and the PTT. They might be put on warfarin long term. Remember, you could be on heparin and warfarin at the same time because they work on different clotting factors. So monitor the PT, monitor the INR. Okay, complications of having an MI for person who can't get to the hospital and have an intervention, or even when you get to the hospital and have an intervention. You can have a fatal dysrhythmia, which is the most common cause of death in people who sustain an MI. You can go into heart failure, and I think you can see that now that you know that heart tissue does not regenerate, and when you lose a portion of your myocardium, it doesn't contribute to the cardiac output. And sometimes, like the patient who had a myocardial infarction that involved the left main, you lose such a big portion of the functionality of the left ventricle that a person goes immediately into cardiogenic shock. Okay? I still have a few minutes. I'm sorry, I'm going fast. I just want to get it done for you. So surgical interventions for CAD. So sometimes people will not be a candidate for PCI for a multitude of reasons. Either there's no anatomy left to do another stent, or they might just have bad occlusion. But this is a decision that is by the cardiologist, not you. So just know if your patient has a coronary artery bypass or a cabbage, which is what it's called, this is what you have to worry about. So basically, during the procedure, a patient will be put on cardiopulmonary bypass machine. This way, the blood is removed from the heart, okay, and it is circulated in the rest of the body through a machine that's oxygenating it, keeping it at the appropriate temperature, and returning it back to the person's body, but bypassing the heart. Why? Because the surgeon has to be able to operate on the coronary arteries. They need a bloodless environment. The myocardium will also be injected with potassium chloride because that will paralyze the heart so that the surgeon can work on a non-moving thing. The patient is kept hypothermic during the procedure. Hypothermic during the procedure to slow the workload of the body down. The patient will also be anticoagulated. So all these things that are happening to the person during the procedure are things you have to pay attention to of the effect of these things post-op. I've had a patient who's hypothermic. You got to worry about later on that they're hypothermic on you, right? My patient's anticoagulated. I got to worry about coag factors and could they possibly be bleeding after. All right? Also, patients who have open heart surgery will automatically have 2 chest tubes put in, one interior, one posterior. They will have a pacemaker put in because when they inject the myocardium with the potassium chloride to paralyze it to operate on, they then have to shock the heart to get it beating again, and that's what the pacemaker is all about. Okay? Just in case the shocking of the myocardium after doesn't work, the pacemaker is the backup. All right? They will also, of course, have an indwelling urinary catheter. What do you got to worry about after? Everything that would be related to this. Hemorrhage, like I told you, they're anticoagulated. You worry about dysrhythmias. The myocardium does not like to be touched. It likes a nice, stable environment. As soon as you manipulate it, as soon as you change the electrolytes or irritate it in any way, that's how dysrhythmias occur. The patient could sustain an MI from this. They can get fluid volume excess or deficit. They can get tamponade from the blood clotting around the surgical site. They can get sustained hypothermia. I told you they kept the patient cool. They can get cardiac failure, stroke, AKI, hepatic failure, infection. This is actually a picture of a bypassed heart, and here is the vessel that was bypassed. Okay, I'm going to keep going. We're okay with this, so we finish these few slides, everybody? Okay. So, nursing post-op, A, B, C. I'm going to assess the airway, assess the breathing, assess the circulation. Okay? How do I assess the circulation? Vital signs, urine output, skin turgor, catheter fill, yada yada. Who's talking? Belina?
Yeah, pulses, right?
Oh.
I said pulses for circulation.
Yeah. Yes. Okay, so frequent assessment of vital signs. This is important. You have to notify the healthcare provider if the patient has an elevated BP because the increase in vascular pressure can cause bleeding at any surgical site. Typically, once this patient comes out of the OR and the PACU, within 24 hours, the chest tubes come out, the pacemaker comes out, they look great and they feel great because you have now reperfused their coronary arteries, so they look healthier than ever. But it's up to the nurse to catch the subtle changes that might tell you that they're having a complication. So frequent assessment of respiratory status, cardiovascular status, neuro, GU, and hepatic function. Frequent assessment of fluid and electrolyte balance and all their labs. You're assessing their skin, the temp, color, pap refill, turgor, like I said. You're assessing for internal bleeding, okay? That's the level of consciousness in case it's cerebral. That's the abdominal girth in case it's internal. They will have a chest tube, and if there's any drainage more than 70 mils an hour, you have to call the healthcare provider. Typically, drainage just goes down and down, and it comes out. You have to assess for signs and symptoms of cardiac tamponade. Cardiac tamponade is a condition that can happen from the accumulation of blood clotting around the myocardium from the surgery. And what happens is it creates pressure on the heart so that the heart doesn't beat effectively. When you listen to this person in their chest, you hear their heart beating, and it seems like it's almost at a distance. It's very muffled heart sounds that you hear. And that's an indication that there's fluid, clots, whatever, building around the myocardium, and the heart's not able to beat effectively. And think about it, all the symptoms. If the heart's not beating effectively, cardiac output's going down. So this person's going to be tachycardic, hypotensive, and when you listen, have muffled heart sounds. You want to take care of pain management for them. And you want to assess for signs and symptoms of infection at the surgical site. Okay. Post-op teaching for your patients. They got here because they're maybe smoking, maybe not, but more than likely they have elevated cholesterol and triglycerides. So at the right time, you're going to talk about medication compliance, diet, physical activity. Everybody wants to know about sexual activity, and that's told to them by their healthcare provider. Pain management. Typically, if they're cutting the sternum and doing a cabbage that way, that's when people really have a lot of pain, but they're kind of moving away from that approach now. So pain is a lot less. And you want to teach them when to get medical assistance, like they're home and they suddenly spike a temp, or they're suddenly short of breath, or really experiencing anything acute. They need to notify their healthcare provider. A lot of times people who have open heart surgery and cardiac issues, and even when they get resolved, have a lot of guilt. And it's usually of the kind that, oh, I knew better, I should have changed my diet, I should have stopped smoking, I should have this, I should have that. And they have a lot of guilt about their recovery. So someone like that, it would be good to recommend them to go to cardiac rehab. Cardiac rehab offers emotional support, but also offers physical support, like exercise programs and stuff like that, while the patients are actually being monitored. Okay, this is cardiac tamponade, which I mentioned. It's an accumulation of fluid and clots around the accumulating around the heart in the pericardial sac. So I think it's kind of clear to understand that we have this external pressure. So this would be a cause of non-cardiac cardiogenic shock, right? So we have this external pressure exerted on the heart from the clots and whatever fluid might be accumulating, which is preventing the heart from forcefully contracting to have an effective cardiac output. This is a medical emergency. If you hear the muffled heart sounds, the patient has to go right to the OR to get it rectified, all right? Another thing that you might notice with someone who has cardiac tamponade, in addition to all the signs of decreased cardiac output, is, is they would have a paradoxical pulse where you would see the pulse doing the opposite of what it should be doing on a waveform. But the muffled sound is key, okay, with cardiac tamponade. Last two slides. Sometimes a patient is a candidate for cardiac transplant surgery, and now that we have, there's a lot of options now for people with end-stage heart disease. And the things that are making this more popular is techniques have improved dramatically, as well as immunosuppressive therapies, so people don't reject the hearts that get transplanted. Indications for people getting heart transplants: one is cardiomyopathy. In cardiomyopathy, the heart becomes abnormally enlarged and then becomes an ineffective pump. So basically, people with cardiac myopathies have a high risk or are in cardiac failure a lot. Also, someone who has ischemic heart disease, valve disease, congenital disease, those are indications for cardiac transplant surgery. Another indication is someone who has symptoms that are still uncontrolled and they've been on the maximum therapy that they can be on. They would be a candidate. It's a multidisciplinary decision. A lot of things are weighed when patients go for transplants: comorbidity, psychosocial status, what a person's compliance is, and what their current health status is. Some complications of getting cardiac transplant surgery are, of course, infection, risk of rejection, which I realize that should be in there, risk of rejection and infection. and people who have cardiac transplants are prone to having accelerated atherosclerosis. Okay? Post-operatively, the patients are on special diets, medications like steroids, anti-rejection medications. There's a whole activity regimen, labs, biopsies, and healthcare provider visits that they have to go through. This is kind of interesting and important. There's special considerations when people have heart transplants. And one very big consideration is if you were the patient who typically had anginal pain, people who have heart transplants do not have chest pain anymore. Because when they transplant the heart, they are not transplanting all the nerve connections. Okay, so we basically have a heart that's in someone's chest with no nerve connections to the rest of the person's anatomy. So you have to tell your person you are no longer going to experience angina like you had before, that they have to be cognizant of other symptoms they might be feeling if indeed they are having angina. Okay, so they might get congestive heart failure and, can't figure out why am I suddenly short of breath, coughing up sputum, whatever. They possibly could have had a silent MI because they're not feeling the pain anymore. All right. Also, typically, the resting heart rate of a transplanted heart is 90 to 110. So if you had a patient with a transplanted heart and their heart rate was consistently 110, that is normal for them. When people with transplanted hearts exercise, you need to tell them they need a prolonged warm-up period and a prolonged cool-down period. Another interesting thing is, if a patient with a transplanted heart goes into a slow cardiac rhythm, atropine will not work for them. Okay? Atropine will not work for them. So the only recourse there is a pacemaker. Digoxin does not work on transplanted hearts. Okay? And like I said before, patients who get transplanted hearts have a higher incidence of getting atherosclerosis faster than non-transplanted heart. So someone is saying so Tammy, listen to what your fellow students are saying over there about the slides. I know I gave you a lot, just kind of wanted to get through today so we don't have so much hanging for next week. Any big questions about today? Nothing? You're all like in cardiac shock again? Cardiogenic shock of a non-cardiac?
I don't know if you...
What?
Professor, I don't know if you spoke about the flipped classroom before I came in because I was having problems with the Zoom link.
Yeah.
But I couldn't find the case study. I did the interactive learning. I found it on chapter 25, but I couldn't find the case study.
The case study for the flipped class. Yeah, it's the woman. It's a PowerPoint. Let me go into Brightspace. Oh, come on, are you kidding me? I have to log in. Did anyone else find it? Or is it not seriously not there? Because sometimes when stuff comes over, let me pull it up for you.
Is it a Joan Smith case study?
Yeah, it's the woman.
This one?
Hold on. Yeah, that's her. That's her, Natalia.
Okay.
So let's see. Let's find it. So lecture.
Under the lecture. Okay.
Yeah, hit the lecture tab. Go down to flip class. I just saw it. Flip classrooms, burns, pneumonia, TB, peri-op, heart failure. It's there. You see it, Lena? So it's lecture, flip class, it's the very last one, heart failure flip classroom. And in there, oh, interesting, I put the answer key up. See the student heart failure, any reasoning? You
Yes.
see it? So
Yes.
that's where it is. Try not to look at the, whatever. So, what we'll do on Tuesday is your heart failure flipped class. And then, what else is on the roster? What's the matter? So Tuesday, we're gonna do heart failure and have the PVD handout done. And I'll do PVD really easy. And hypertension and anemia also pretty straightforward. Okay, we'll get into doing rhythms on Wednesday. That will be the whole class. So for Wednesday, you need the 10 rhythm strips copied. It's easy to learn the rhythm strips when the paper is in front of you. You don't need anything special. For today's lab, sorry, I'm not going to be there. This is a new lab. I hope you all did call Shapiro, but now you have plenty of time to do it. Get to school on time at 12 noon. Professor Shannon's and Ficarelli will be there, okay? The lab is directly related to Carl Shapiro. He's gonna be your patient. So if you did call Shapiro, the VSIM, in the classroom, you're gonna do the concept map with them. So you should have that completed when you get to class. And I included a cardiac assessment that you should use when you're assessing Carl in the sim lab. And then you'll go in and do your sim. So be there on time for them, please, at 12 noon. You have a lot of time left now. Any questions about today? I know it was a lot. Natalia.
Yeah, I have a question. You said the patients with stent should be on the antiplatelet therapy for the rest of their lives. So if they are hypertensive, they are in the constant risk of hemorrhagic stroke. Am I right?
You're talking about because of the platelet
Yeah.
Yes. Anything
Yeah.
can happen, actually. They're on aspirin too for the rest of their life. So that's why patient teaching is really important, to tell your patients, to teach your patients how to, notice if they're bleeding and something's happening. Yes.
So if they are fall down or something happened to them, they're high risk that they were bleeding to death, right?
Of course. Yeah. Yeah, and it's something like they go for dental work, they have to tell their healthcare provider, pretty much anything that they do, they have to tell somebody because they have the antiplatelet on board along with the aspirin, and both are going to affect, their bleeding risk.
And I have a question regarding patients with diabetes. I know that they have problems with their blood vessels, so they are at highest risk for their coronary
risk factor. We talked about that from the very beginning when we spoke about risk factors. People with diabetes have the highest risk factor for coronary artery disease because of the changes that occur in your blood vessels all over the body because of diabetes. So yeah.
And they can be not best candidate for the PCI, right? Because of the vessel.
That's left to, the cardiologist. There are patients who are diabetic that get PCI. It depends. There's a lot of different criteria that determines the treatment that patients get. Okay.
Okay, thank you.
You're welcome. So any other questions about anything today? I know it was a lot. Please, I urge you to make an appointment with me to do a concept review of your exam. If you scored, I'd say less than 80%. Okay, less than 80%. Please make an appointment with me. I'm going to give you a few days. Otherwise, I'm going to send you an email that says I scheduled you to meet with me on this day and time. I am going to be on campus Monday. So if anyone wants to meet me Monday between 12 noon and 1:15, shoot me an email because I will be there. Otherwise, Tuesday, I have 12:15, 12:30, and 12:45 available. And I have a few spots on Wednesday the 9th in between our lecture and lab. And then we go on that long break, okay?
Okay. Professor, could you please repeat the time for the next Tuesday for me?
Natalia, you have 12 noon next Tuesday.
Thanks.
Somebody just took 12:15. Okay. I mean, you can put it in the chat and send it to just me if you don't want everyone to see it.
What's the other times that you have available? If you get if you didn't get less than that, can you still have a meeting with you to go over the exam?
Yeah, but I'd like to see the people who were at risk first. So my next availability is on Tuesday at 12:45 and Wednesday, the 4 slots between our lecture and our lab. So I just got the people who just gave it to me again. I don't know what that means.
If nobody wants the 12:45, I could take the 12:45. Or if not, I see you on Wednesday.
I'll pencil you in for 12:45, Maria.
Thank you.
Actually, you won't be able to do that because you have.
I have the.
Yeah.
Professor, can I get the spot on Wednesday between our lectures?
You don't want to take the Tuesday, Ayuna, because I can't do it. I have the tutoring.
And Tuesday I'm going to the.
Okay.
She goes to her thing. So. Oh, I'm sorry about that on Tuesday. So that's gonna knock a few of you off.
Yeah.
So, Professor, can I take that one? If nobody takes the 12:45 slot, can I take that one?
You go to tutoring as well.
Okay.
Summer, are you on here?
Yes.
Summer? Tuesday you go to the thing, right? So you can't do Tuesday. You want to switch Summer to Wednesday? 10:30?
Sure, I guess. Fine.
Yeah, in between. Then I can put Shane at 11:45 on Tuesday.
Perfect.
And then Cammy, you're going to Wednesday 10:45. Cammy? Okay, Wednesday 10:45. So now Tuesday opens up. I have hold on. Tuesday I have 12:30 and 12:45. Anyone?
Professor, can I 12:45 on Tuesday?
Who's talking?
Lena.
Alright,
You said 10:30 on Tuesday. I could do 10:30 on Tuesday.
No, we're in class at 10:30 on Tuesday, Maria. You have to do Wednesday.
Don't we finish at 10:10 on Tuesday? No, we don't.
Tuesday we
11.
finish at 11:20. Maria, do you?
Can I get the 12:30?
Yes, Tashina, I hear you.
Okay. Professor, for Ayuna, can I get on Wednesday?
11 o'clock, Ayuna.
Thank you.
Okay, so Tuesday 11:30 Anastasia, 11:45 Shayna, 12 noon Natalia, 12:15 Tazia, 12:30 Tashima, 12:45 is open. 10:30 on Wednesday Summer, 10:45 Cami, 11 o'clock Ayuna, and I have one 11:15 spot.
Can I do 11:15 Wednesday?
I'm leaving those spots open for some people that I'm expecting to contact me directly to get an appointment. Otherwise, I'm coming after you. Tammy, I got you. I took you out. And that's Wednesday in between. Cammy, you're a no?
No.
Okay. All right, so I'm gonna leave it as is. I'll leave these 2 spots a few days. If I don't hear from anybody, you get an email from me, Maria. I'll put you in when the rest of that's settled.
Got it. Thank you.
Professor Zaloom,
Yeah.
I just sent you an email, but I figured I can just ask right now. Can I come in at 12 o'clock on Monday?
Yes, you can.
Thank you.
Professor, can I do Monday 12:30 instead?
Who just said that to me?
Summer.
Sure. Summer 12:30, perfect. Okay. So I'll end this so you guys can get yourselves ready to get to class. Let me make sure I got everybody in the chat. Okay, so everybody's done. All right. I'll see you guys next week. Enjoy your lab. Have fun with it. Pay attention. It's gonna be exciting.
Thank you. Have a good day.
Thank you.
Thank you, Professor. Feel good.